tune in to listen. They still tune in for these lectures. It's a pleasure to introduce our speaker today, Connie Chang, who is an assistant professor of radiology at the Harvard Medical School. Connie is heavily involved in resident and fellow education. And for those things, she wears multiple hats. Two of them that I can think of are the director of the MSK Radiology Education, and she's the program director for MSK Imaging and Interventional Clinical Fellowship. But she is also a researcher. One of the things she's working on right now is the treatment and image-guided sclerotherapy for aneurysmal bone cysts, among other interventional things. She's also one of the leading authors in the CT attenuation thresholds to differentiate between anastosis and meds, that article that most of you probably have read, and it's very helpful. I can keep going on and on and on, but I think the reason we wanted to bring her here is because she is really an MSK interventional person, and we need to learn a lot from those things at our institution. So I don't want to keep you any longer, and she's going to talk to us about fluoroscopic intervention and how to do lumbar spine injections. It's all yours, Connie.
Thank you so much, Monica, and thank you to everyone at Emory for inviting me, and to the Honduras residents for getting up at 4:30 to attend this talk. I really appreciate your time and your attention. I just want to let you know also that I will be using the polling function every once in a while, so get your clicking hand ready when we get there. All right, so we do in our practice a fair number of a pretty broad spectrum of injections, but as I was preparing this talk, I realized that I probably only have time to talk about these two, which is the main bread and butter of what we do. One is the interlaminar epidurals, and then the laminar nerve blocks and transforaminal epidurals. But I'm going to go carefully through all the anatomy and how to do things. And so really, I feel like by the end of this, hopefully you may be comfortable trying them on your own, or at least thinking about it. And then also, once you really understand all the anatomy, you can do any of these. Really, it's just about knowing where to get started. All right, so the first most important principle, as I kind of already said, for all these injections is, when I searched for know your anatomy, this is what came up, but really it's knowing your anatomy is basically the basis of being not only a successful interventionalist, but just a successful radiologist in general. So we're going to focus on anatomy in the beginning, and when you're doing these fluoroscopic injections, what you're looking for, and also actually, if you understand anatomy, if you run into problems, then you can troubleshoot them. So take a second here first, just in your mind, real quick, go through and check off real quick, circle, you know, like end plate. Okay, here, I'll give you just 2 or 3, maybe 10 seconds just to do that in your head, and then we'll go through it. All right, so starting at the top, so the end plate, I just want you to notice that on every level, you know, sometimes you see part of the end plate on FOSS, and sometimes you see it straight on, and this is important as we start lining up the beam to do these injections. So, and then of course, between these is the intervertebral discs, and at every other level, at the upper levels, like the most common when we do injections is going to be L4-5, and then L3-4 and L5-S1 are probably the next most common. Most of the upper levels, you can see at least some of the intervertebral disc profiles, but L5-S1 is really the different level, and it's different for many things you'll see. It's different when we do the facet injections, it's different when we do the nerve root blocks, and the main reason is because, the angle is a little bit different. So you can see even here on the on the AP, you don't really even see the disc at all. So we'll talk a little bit later how we can visualize that a little bit better. All right, and that's important for access to being able to get to that space. All right, so here are the pedicles. Here's the lamina, which is lateral to the spinous process, which marks the midline of the patient. And this is important, a landmark when we're doing the interlaminar injections. And then underneath the lamina, sorry, this is the midline, and underneath the lamina is the paralaminar arch. Now, I like this particular patient because you can see even within this one patient, the paralaminar arches all have very different shapes. And this is a key because when we do the interlaminar injections, we're actually coming from slightly from the side. So a lot of times I think mostly in the anesthesiologist, they come straight between the spinous process, so actually inner spinous. We come a little bit to the side, so the shape of this paralaminar arch is going to matter in terms of how we line things up. And there's always the ideal, like, so probably this nice skinny narrow one would be the most ideal, but sometimes it's pointy, sometimes it has weird shapes, sometimes it's broad and flat, and that always throws a little bit of a wrench in things too. So just keep that in mind. Here's our transverse process. These are facet joints, and again, notice that L5S1 is the level that looks a little bit different, and I think it's also because the L5S1 level is a transitional level, right? So from lumbar spine is quite mobile, allows you to do a lot of things, flexion, extension, and lateral bending and twisting, but as you're moving to the sacrum, you're going to weight bearing, so instead of being more vertical, the facet joint becomes more horizontal, and often a lot more difficult to visualize, but in your mind, you just kind of have to remember that it takes on a slightly more oblique than vertical shape. But sort of in the craniocaudal dimension, it definitely lines up with the other levels. All right, neuroforamen, you're probably like, how can we see the neuroforamen on a radiograph? We don't see it, but it's a space. And we're gonna go over exactly what that space is. So in a sagittal, this is a sagittal slice through an MRI through the level of the pedicles. And here is the neuroforamen, and in your mind, always think of it in terms of quadrants. So this would be the upper inner, this would be the upper posterior, upper anterior, upper posterior, and then so forth. And so here, where I draw the X, this is the nerve root. You can actually see the nerve root coming out. So this is where we're going to be targeting when we do the nerve root blocks. And then here, you can see back here is actually where the facet joint is, where I've marked. So whenever you're doing fluoroscopy, you're basically condensing 3D down into 2D. So if you squish this like a pancake in this direction, you see that your needle always has to pass over the facet joint and under the pedicle in order to reach the area where the nerve root is coming out of the neuroforamen. Okay, so if we go back into here, looking at the AP radiograph, you can see that you have to go again over the facet joint and under the pedicle, and then your needle is going to end up somewhere right here underneath the pedicle. Usually we say 6 to 7 o'clock on this side and 5 to 6 o'clock on this side if you think of the pedicle as a clock face. Also, when you look at that then, if you look at the upper levels, you can see that the space between the facet joints and the pedicles is much greater when you're at the higher levels, but as you come lower down, you can see it's much more narrow. And this is an issue, and we will talk about that. Part of the reason is also that the facet joints down in the lower levels is more bulky, but part of it has to do with the anatomy. Remember, I was telling you that the L5S1 disc is angled differently, and so that can come into play as well. So while you're thinking about that, and before we get to it, think about which way do we want to angle the image intensifier in order to get around the facet joint, because right now, this line that I've drawn, I can't get into the neuroforamen because I'm going to bump into the facet joint before I get to the neuroforamen. So which way do I want to angle the image intensifier to get around the facet joint? All right, so we'll come back to that. And then, of course, the pars interarticularis, which is here in the space between the two facet joints at the two different levels. And here, the neck of the Scotty dog is where the pars interarticularis fractures are. All right, and then real quickly on the lateral, just going to run through this. So here's the pedicle. Here's our neuroforamen. Here is the lamina, which looks kind of like rolling hills or a stack of triangles. And the paralaminar arch is actually right underneath this peak right here. So the apex of this triangle is the landmark we use on the lateral when we're approaching the epidural space. So keep that triangle in mind. And while you're thinking of that triangle, when my needle tip has reached here, what soft tissue structure is the needle tip within when I've reached here? So keep that in your mind, store that in your mind while you, as we move forward, and we'll go over that later. All right, so here again is our facet joint, which is important to remember, and also that in this orientation, the facet, on the lateral view, the facet joint has this orientation here. This is important to keep an eye out for, because sometimes contrast can accidentally go into the facet joint, and we'll take a look at what that looks like later. Here's our spinous process, and here's our transverse process, just remembering that also that can be a roadblock. If you're too high, you can also bump into the transverse process. All right. So a quick note on the tools of the trade. So here is our C-arm. This is one of our fluoro rooms. And just always remembering that the source is underneath the patient and that the detector is above. And that's what I'm going to refer to as the image intensifier. So when I say I'm moving the image intensifier, or II, cranial, or caudal, I'm saying that I'm moving it towards the head of the patient or towards the feet of the patient. And this, again, it moves in either direction. All right, and just note to the trainees, make sure you learn how to drive the machine before the patient is in the room. It's really terrible when you show up and you're just figuring that out. It decreases the patient confidence in you so much. So before you do your first injection, always remember, make sure you go in the room and just figure out how to use all the controls and learn the limitations of your machine. Okay, so just one more basic thing before we start showing cases is, what is the correct orientation of this image? And I am going to make this a poll. There's more than, hold on. There's more than 5 answer choices, but just pick either 1 or 2. So which is the correct orientation of this image? All right, there's 11, so I'm going to wait till it gets to at least 20. We're at getting close. All right, so I'm going to end it there. And so interesting, well, we had some people who picked 4, but really it's about half-half in terms of the people who pick the 2 options. So can you guys see this when I move it over? I think you can. Okay, well, anyway, so this is something that's very confusing, which is why I'm going over it first. So the number 1 is actually the correct orientation of this image. This is the patient's left, and this is the patient's right. And why is that? Well, because when we do these lumbar injections, the patient is prone on the table. So imagine the patient prone on the table and the source coming from below and coming up. Left is actually left and right is actually right. So those of you residents and fellows who spent all your time, trying to learn the radiologic right and left, well, for these images, you now have to swap it in your mind again. And it takes a little while to get used to. But anyway, so I don't want, when I'm talking about the image, I'm saying left and right, and you're getting all confused because, now on these images, when we're looking at these cases, left is actually left and right is actually right. Okay, this is the correct orientation. So keep that in mind as we go forward. All right, excellent. All right, so our second most important principle is that patient positioning. Anytime you do any procedure, patient positioning can make or break your procedure. So planning that ahead of time, and that ranges from how you have them on the table, whether you put a wedge underneath them. In cases of spine procedures, sometimes we'll put a pillow under their stomach to create a slightly different, to kind of flatten out the kyphosis. But it can also just be making sure your patient is comfortable. Because, if you have a young guy and you're doing a procedure, probably it's not going to be an issue, right? But now you have an older person who has a lot of pain, who can't stay still, if they have pain, and then add on top of that, older person with pain, or if they have these crazy scoliotic curvature. I was telling the Emory faculty before that, a lot of the PM&R people, this is the kind of case that they send us. And so if you don't position the patient properly to begin with, for any procedure, this is ultrasound, CT, fluoro, whatever it is, you may end up in trouble. And so always practice getting, always operate by that principle. Don't skimp on that extra time and making sure that the patient is positioned properly before you start any procedure so that you'll never get into trouble because of that. All right, and then lastly, in terms of the tools, so we use a 22 gauge spinal needle for most of our procedures. And there's something very interesting about this needle, which is that it has a bevel. And this bevel means that the needle tip will tend to drift away from this bevel. So as I advance, it's going to move in this direction. And the notch that's on the top of this needle actually is in the same direction as the bevel. And so this is important sometimes when you just, because remember that the needle, always remember, the needle is really like a vector, and it's not a point, even though, you know, we try to bullseye it on the screen, but really it's a vector. And as you're moving it, there's always going to be different forces on this vector. And one of these is this natural tendency to drift away from the notch. And we can use this, since we know this, we can use it to our advantage, but also we want to remember to make sure it doesn't fight against us. So just keep that in mind as well. All right, so we can use the bevel to gently steer the needle. And also sometimes we add a slight curve to exaggerate this drift, and it's primarily for nerve root blocks and where we use a curved needle approach, and I will show you some of these later on. So, and the curve is very slight. Because the other thing is that if you ever alter any of your tools, make sure that you pull the stylite out and check to make sure the thing isn't stuck inside, because I have had that happen before. And you also don't want to be too aggressive on the curve, because these needles are pretty fragile and they could break inside the patient. So, you know, a very gentle curve just to exaggerate this drift and help you to be able to steer it better is the goal. All right. So I'm sorry, and last but not least, so just a quick primer on steroids. So there's actually a pretty broad, if you look in the literature, there's a pretty broad range of things that people use. But the main difference between the two sides of the yellow line is that this left side they are one of these things. And actually, I'm just going to skip ahead because of the time, but basically it's a suspension. So, and what does that mean exactly? So, you know, if you add salt, table salt, NaCl to water, the salt and the salt crystals separate, or the two ions separate, and they distribute evenly within the water, and they stay dissolved even if after you leave it on the table for a while. But but Kenalog and all those steroids on the left side of the screen are actually suspensions. So what they are, they're crystals. And when you put crystals into water, even if you shake it up, the crystals kind of float around, but nothing chemically has changed about them, like the ion separating for the NaCl. And so if you leave it for a while, it'll actually settle back to the bottom, just kind of like if we have sand in a jar. So if you shake up sand in a jar of ocean water, that's going to be a suspension. And so these steroids are these suspensions. And so you can see here, I picked up a new jar, and you can see that the crystals are sitting at the bottom. And then also, if you just leave the syringe, when you draw it up, of course, you always shake it up, but when you leave it in the syringe, even just a couple of minutes, it sinks to one side. And this is important because you need to, if you don't, you might not get the correct dose because, you know, the crystals probably get left behind, and you also could clog your injection needle. So always make sure that you agitate it and recreate the suspension right before you inject. And then why do we use these particulate steroids? Well, a lot of it, if you read the literature, it is a little bit controversial as to whether or not it actually does anything. But the theory and thinking behind it, and some, you know, sort of case report-ish type, not case report, I mean, they've done case series and case control studies, but is the idea is that the insoluble crystals, they require hydrolysis to become active. So if they hang around in the area that you want it to be active longer, then hopefully it can last longer and sort of become this slow release and work longer over time, as opposed to a soluble steroid like dexamethasone, you know, probably gets absorbed into the system within 20 minutes. So that's the theory behind it. We currently are using betamethasone in the spine. We used triamcinolone for years and years and years. And then somebody one day looked at the package insert and found that it says that it's actually not indicated for spine injections. It's not, yeah, anyway, so something came up and we decided that we were going to shift over to this because it is, I guess, officially by FDA approved for spine injections. But if you look at the literature, any of these are used. All right, so the risk of doing particulate steroids is rare but catastrophic. So you can imagine that if you have particles, then they can embolize, and if they embolize, you can cause infarctions of the cord or brain, depending on where you are. And these have been reported in the literature, so it's no joke. And so our policy is that at the level of the cord and above, we always use a non-particulate steroid. And then you always want to check for inadvertent intravascular flow, because and also even like if you have a little bit of gas inside your tubing or inside your syringe, you could cause a little air embolus too. So that's why it's always important to check for intravascular flow. This is what I find my fellows, they always get so happy that they're in the space already, but they don't inject enough to make sure that this isn't happening, because this is what we're trying to avoid here. So anyway, always check, and I'll show you what that looks like a little bit later. And then other risks of steroids, adrenal suppression, it's a really real thing. Of note, especially there are some HIV medications that actually in combination with steroids can cause adrenal crisis. So, you know, it's probably not a major issue in most people, but in certain situations, or if you know the patient has adrenal insufficiency, you definitely want to be careful giving steroids. Patients definitely have poor, with diabetes, definitely have poor glucose control for about a week. So we always tell patients to double check their steroids, double check their blood sugars. If they have any symptoms, definitely to seek their primary care or endocrinologist. And then anecdotally, it does cause, for the same mechanisms, some temporary hypertension, and maybe immune suppression by the adrenal suppression as well. So this is one of the questions that has been circulating around. You know, a lot of the European societies in particular during the time of COVID recommended that, you know, people definitely don't inject steroids as much because of the unknown risk of immune suppression. We just looked at a case series of ours during the lockdown period, and we didn't find any increased risk of COVID during that period, and we're still following our patients now because, you know, I mean, myself in particular, I am worried about this. I think we didn't see any increase in the lockdown period because everybody stayed home. So now that things are sort of unstable, you know, we'll see what happens. But anyway, so stay tuned. This is still a question that's unanswered. And then just sort of minor reactions. Patients can get this flushing syndrome of their face, and it's very uncomfortable, but it's not an allergy, and it goes away within 48 hours. All right, so the recommendation in general right now, especially with COVID, is always, and in general, always use the smallest effective dose. But on the other side of the coin is that means that they might have to come back multiple times, or the dose they didn't help them, but still has associated risks. So anyway, just things to think about and ponder. Last note on anesthetics, most of the concerns are related to chondrocyte toxicity, so they're not a concern for spine injections, but for us, we used to use some longer acting anesthetics to give them a longer pain relief, but there's always the risk of, if you have accidental intrathecal injection, or even just the patient is sensitive and you end up with nerve palsy, then lidocaine doesn't last as long as bupivacaine or ropivacaine, so we've stopped using lidocaine. And then again, because of the risk of potential intravascular injection, we don't use any anesthetics with epinephrine. All right. So anyway, my 15-second soapbox. Interventions are not completely benign. Sorry, I spent so much time on this, but before you embark on anything, make sure you understand the risks and benefits of the patient, and always do no harm. All right, finally, the injections. Sorry, it took a little while to get here. So we're going to start with the interlaminar epidural, and now that we've gone through all the anatomy, hopefully you'll be able to understand, you know, where things go a little bit more easily. So the goal of this is to reach the posterior epidural space, and the maximum posterior epidural space is pretty much at the level of the end plate of the level above. Meaning, if you're at L3-4, the maximum epidural space is at the inferior end plate of L3, so where my X is and where I've drawn this line. And so our needle approach is going to be something like that. Remember, we're going to pass underneath the paralaminar arch and get to here. But the goal of the, what you're aiming for is at the level of the inferior end plate, but that is about 2 to 3 centimeters anterior where your needle is going to end up. So if you aim for that, you're actually going to end up a little bit lower. So I always aim my needle a little bit higher. And we'll talk about how to do that when we look at the fluoroscopy images. All right. And then now looking at the axial images, again, so here is our goal right here. Here's the fecal sac that I've outlined. And here is our goal. That's where we want the needle tip to be. So we want the needle tip to end up in the midline in the posterior epidural space. And that's, again, where the epidural space is the widest. But also remember that the epidural space is contiguous around the thecal sac and also with the epidural space. So you may see contrast flowing into these areas as well. The facet joints, so on the lateral view, when we're bringing our needle in, the anterior safety landmark is the facet joint. You can see them here, right? So when you see it approaching the facet joint, you have to start being worried that you might be a little too far anterior. So anyway, so that's our safety margin. All right, and so where's the paralaminar arch in this situation? I keep saying this is how we get to the space. It's in these X's here. So this is our approach. If you're thinking about it on an axial slice, this is how we're getting to this space. And so I asked you the question before, when you're under the paralaminar arch, you know, when you're right there and just a little bit anterior, what do you have to go through in order to get to the posterior epidural space? And the answer is the ligamentum flavum. So that's this thing right here. All right. And that's important because in most people, not in all people, but in most people, you will feel a texture change in the needle as you advance through that. But it's a varying thickness, and the force required to traverse also varies. And it's a very small window. I mean, on this side, you can probably measure it, but here, you know, it's almost imperceptible if you're coming from this side in terms of measuring it. So, you know, I always tell my fellows, don't rely on feeling the ligament. If you feel it, great. But if you don't, you know, don't think, oh, I didn't feel the ligament, so I'm not there yet. All right, so I'm going to go through the images that we acquire as we do these procedures. Always get a scout of the entire spine, because there might be, you know, of course, we've reviewed the imaging before, but sometimes you may have missed or forgotten that there's transitional anatomy. And so this allows you to count and make sure that, that you're not going at the wrong level. And then count using the spinous processes, because the discs, remember, are at different obliquities, so they can be difficult to count sometimes. So I always count the spinous processes and best from below, and just making sure that you have 5 levels. And then you find the corresponding level and the paralaminar arch. So say we're going at L3-4. Here is my L3 spinous process, and underneath it, that's my paralaminar arch. And then I oblique the patient to one side. And that's which side that we choose depends somewhat on patient pain. So if they have more pain on the left, we tend to oblique it to the left. And if we, you know, approach on the left, even though the needle ends up in the midline, and in general, flow is if flow goes to both sides. But when you come from the left or you come from the right, it generally does tend to flow a bit more, probably because of just you know, path of least resistance, a little bit more on the side you approach. So anyway, we come from the side that the patient has more pain, and if they don't have if it doesn't matter, then we usually do the right side, mainly because if you do the right side, the eye isn't in your face. But anyway, okay, so on this image, remembering that, well, we went over this before, so that this is the left side and this is the right. Which side are we targeting here on the patient? I'm going to relaunch the poll. And again, only use the first 2. I'm going to wait for a few more votes. I've got 10, 11, 12, 13, 14. I'll wait till I get to at least 20. Come on, guys. All right. Oh, somebody's still popping in. All right, so we came up a little bit, almost even. So, but most 60-40, most people said that it was the left, and this is the left side. So if you imagine starting from an AP, as you bring the II to the right side, you're going to open up the left side. It might be hard to actually, you know, visualize this without doing it. So we have like a, you know, find like a skeleton and do this with the fluoro, move it back and forth, and so that you can see how the obliquities change as you oblique it. But anyway, this is a left-sided injection. So, sorry, so yeah, remember the patient is prone. And So remember, our target, our goal is to be midline and the tip of the needle at the end plate of the level above or a little bit above that. So here there's L3-4. So midline is marked by the bases of the spinous processes. So that's this dotted line here, and here are the spinous processes coming out. And so that is our target goal. And you want to line that up with the roof of the paralaminar arch, the top of the paralaminar arch, and you want to target a little bit above the end plate, remember, because of the way the anatomy works out. All right. And ideally, again, the peak of the paralaminar arch lines up with this dotted line. However, again, because every paralaminar arch looks different and has different anatomy, in this case, it's just not achievable. So you do the best that you can with what you have there, but this would be the ideal. Okay. And again, there's different shapes of paralaminar arches here, and this one here is the base of the spinous processes here, this line, and then you can see the arch here, and it is lined up with that base. So, because it's a much narrower paralaminar arch. All right, and then again, remember that here at this point, so this is, you can see the hub of the needle down here and the tip up here. Your goal is to be up all the way up here. So remember that you always think of your needle as a vector, not just a point. Of course, ideally you have things bullseyed, but especially in spine, you really want to think about it more as a vector because of the challenges that may come in between. So good or bad needle positioning or appearance depends both on the current appearance of the needle and the distance to the target. So if I needed to be here at the target, within a few millimeters, this would not be good. But if I'm still, in the subcutaneous soft tissues far away, this is actually a really good trajectory right now. So that's my goal there to target. All right, so now when I flip to the lateral view, this is at the L3, we're targeting the L3-4 level here. Remember our chain of mountains back here and these little triangles. And our goal is to aim just below the peak of that triangle because that's where the paralaminar arch is. And at the triangle, you will enter the ligamentum flavum. So right there. So, when I come to the lateral or when my fellows flip to the lateral, I always want to see your needle just a few millimeters shy of there. That would be the ideal. And of course, in the beginning, when you don't really know, you're not as comfortable guessing the depth, you want to check as frequently as you want, basically. There's never, I never say no to people wanting to check. But anyway, so this is where we're going to enter the ligamentum flavum. Then once you get there, you want to go through the ligamentum flavum, and we use what's called the loss of resistance technique. So you have one hand holding the syringe, and I specifically use this position where I have the top of the plunger against my thenar eminence, and I hold it this way so that I can visually look at the plunger and whether it's advancing. We have things hooked up through this tubing so that, again, we can have better visualization. Then you want the hypothenar eminence of the hand that is doing the advancing of the needle on the patient. And why is that? Well, in any situation, whether I'm doing a biopsy or whatever, I always like to have my hands on the patient and not to be free floating in the air, because when you're free floating in the air, you don't have control. You could push too far accidentally. Say you're pushing hard because you're pushing against the osteophyte, and you push and you get past it. Then you slide in, and then you end up intrathecal. So that's very out of control. So I always like to have my hand directly on the patient so that I always know, basically that I won't do that, because I'm only using my first and second finger to control the needle. And as I'm advancing through the ligamentum flavum, it should be imperceptible. I shouldn't even be, if you're watching me, you would be questioning, is that needle moving or is it not moving? And then at some point, you will see that the plunger will start to move because there's loss of resistance and you're able to inject contrast. And that point is when you start to fluoro. And when you start to fluoro, you'll see this curvilinear pattern of contrast in the posterior epidural space. And once you see this, that's great. That proves that you're in the posterior epidural space, but you don't know for sure that you don't have intravascular contrast yet. And especially for the interlaminar epidurals, we found that you need to inject at least 1 ml under a fair amount of pressure. So like, don't just sort of slowly inject it, drip it in. You really want to inject it so you will pacify any potential vessels. The only caution is that you also want to be listening carefully to the patient, because if you inject too fast, if they've got a huge disc herniation, you can also cause acute critical spinal stenosis. So you don't want to also just, blast too fast. So it's this fine dance between the two that you'll get better at as you do more. So anyway, yeah, caution, don't cause acute critical stenosis. So this is an example. Here we have our needle in the posterior epidural space. We've proved that we're in the posterior epidural space. However, now you see that at both the level above and below, we see these vessels that are in the area of the thecal sac and projecting anteriorly into the vertebral body. And these are probably venous, but nobody, we don't know for sure. So we don't want to inject our particulate steroid in this location. So this is what the intravascular injection would look like if you're doing the interlaminar epidural. So keep an eye out for this. Cement this in your brain and look, this is what you're looking hard for as you're injecting that contrast. So yeah, here are the arrows. And just so this is the correlate on an MR. If you look, could become more laterally on an MR, on a sagittal view, you'll see these vessels. Again, they're probably venous, but just to be careful, we don't want to inject there. And then inject, right, so and do live fluoro as you're injecting. And also in general, whenever you're doing fluoroscopic injections, beware of disappearing contrast. Sometimes people are injecting and injecting. I've done this too before, and I'm like, I don't see it. It's not going anywhere. It's not blobbing up anywhere. It's not flowing anywhere. Well, that probably means you're in a very fast flowing vessel, and that's washing away your contrast pretty much instantly. So if you're seeing disappearing contrast, you want to beware and stop and reposition your needle. Definitely do not inject your medication in that location. All right, so for our injectate right now, as I mentioned, we're using 2 mL of betamethasone, the particulate steroid or a crystalline suspension, and then we also use about 4 to 5 mL of a flush, which is a mixture of lidocaine and normal saline. This is for the immediate diagnosis. So a lot of these procedures are a combination of diagnostic and interventional, right? So the immediate relief is to help decide if we injected the right level, if we've targeted the area that's causing their pain. And so how much they get or whether we can do this, though, depends a lot on their functional status. Like, I'm not going to send, a guy who's driving home or somebody who looks kind of wobbly and doesn't really have, is using a walker. I'm not going to use too much lidocaine, because even though you take away that diagnostic portion of the examination, you run the risk of them falling or something like that, which just isn't worth it. So the important medication for the longer term effect is the betamethasone. And you see the contrast flowing everywhere, and even in the anterior thecal sac. So it will travel anterior, and that's okay. And sometimes it goes anterior very quickly, and that's when you get nervous that you did an intrathecal injection. But if you go back to here, see, this is a little roundish blob. It almost looks like it's suspended. Even though it comes anterior, it almost looks like it's suspended in this potential space here. But here, if I turn, remember that the patient is, they're on their belly, they're prone, right? So this looks like a meniscus. This is the fluid level. And the other interesting thing about this injection is that the needle is actually quite far posterior. So even though we use, this is the facet joint here, even though we use the facet joint as the anterior margin for the safety, doesn't mean that you can't get in intrathecal when you're posterior. And I don't, this is not my injection, so I don't know, but it could be that you're really far lateral, or they have some sort of unusual anatomy, or you're tricked into thinking this is the facet joint that it's not. Although in this patient, it does look quite far posterior. Anyway, so this is an intrathecal injection. It looks like a very sharp line. Also the epidural space, the anterior epidural space will generally conform to the shape of the vertebral body. But this intrathecal injection will basically go to the lowest point, the most dependent point, which is what we see here, rather than conforming to the shape of the vertebral body. The other thing is that if you're not sure, wait a couple seconds and see if the contrast washes away. Because if it washes away, then it's in the CSF. If it doesn't wash away, then you're probably okay. But anyway, so this is, if you see this, this is bad, and you definitely do not want to inject there. All right, so when you go back to the last image you take is you go back to the AP and you want your needle to be pretty much, remember our goal is to be at the midline, which is lining up the spinous processes. So sometimes like this is probably a millimeter to the left and that's okay, but it's pretty close to the midline and we see contrast flowing left, right, and cranial caudal, to cranial all the way up to here. All right, so this is another sort of situation where we injected and now we see this contrast pattern, and take a minute to think about where that is. We pointed this out before, and here's a clue. You can see it actually ended up bilateral and also in this space here. And this is a facet and interspinous bursa injection incidentally from trying to inject epidural. And so the interspinous bursa can actually sometimes communicate with the epidural space, but also you can see that this needle, so this is the AP, and these are the spinous processes. You can see that this person is too far lateral in this situation. And that's probably why they entered in the either the facet or the interspinous bursa. And the reason they got to the contralateral side is that these can often communicate the two facets through the interspinous bursa. So anyway, so that's why you don't want to be too far. You want to aim for that midline because if you're far off the side, you can get an incidental facet injection. And the problem with that is the medication is not reaching the target. We want it to be epidural, presumably because they have a disc herniation. This is only going to the facets, none of it really is epidural in this situation, so it's not helping them. And then here's another related one, but here it's under the pedicle. So this is interspinous bursa and pars injection. Again, the needle tip is a little bit off to the side, so it might be the why we ended up there. So. All right, so and then one thing we also do sometimes is called a caudal epidural, and it's good for lower level symptoms, so S1, L5, that kind of thing. And this is a good thing to use if you have no epidural fat or you've had prior surgery or the patient has really bad scoliosis and just can't get in. So for the L5 and S1 levels. And so the anatomy is basically that there's a small gap in the lower posterior sacrum. So I'm going to scroll through this. So here's the posterior wall of the sacrum. Here's the sacral body. You can see that there's a little gap here, and the epidural fat is actually contiguous all the way up from this level. So yep, you can see that right there, and there's the gap. And so if I come through the coronal, here I'm coming anterior to posterior. Here's the sacral body. Sacral body, and as I come back, there's a little gap there. Next time you look at an ab CT, take a look at that gap, and that's a gap that we can enter into the epidural space. Again, it's good for the lower levels like L5 and S1 if you can't enter. So here, situation, the patient has had a laminectomy, so you can't do an interlaminar injection, and they have hardware, and there might be a reason why we don't want to do a transforaminal injection. And so, oh, and also, yes, the likelihood, so the fact that they've had prior surgery, so that intravascular injection that I showed you, it's higher for patients who have had prior surgery and higher for patients in which you use a transforaminal approach. So when you combine the two, you're at greater risk. So my guess is maybe in this situation, they tried this and it didn't work. So, a caudal is a great alternative. So you mark the midline, which you draw a line down, and here it's in theory, because the spinous processes are gone, but you can still see the spinous processes of the sacrum. You draw that line all the way down, and then you put the needle in right below where it enters in that posterior wall. Right, here's our needle, here's the posterior wall just below that, and you can see that the epidural flow of contrast is flowing all the way up, and actually it's flowing out along the at least S2 and S3, maybe S1 nerve roots as well. And so when you flush, because you're so far down, when you flush, you want to flush with at least 10 mLs. Normally we only do 4 or 5 after the typical interlaminar injection, but when these injections, you want to flush a lot more so that you can push the steroid higher up to the levels, because we don't really want, S2 and S3, that's nice, but that's not where we want the medication. We want it higher up. All right, so, and then we generally don't do these under CT guidance. In the lumbar spine, but in the thoracic spine, we definitely will because of the anatomy, and it's hard to see with the ribs to line up those the anatomy, and also the paralaminar arch is much smaller at the upper level, so we definitely will do it for the thoracic spine if we're going to do an interlaminar approach. And also remember, again, at the level of the cord, we're going to use non-particulate steroids, so use dexamethasone and not any of those particulate steroids that I showed you. but it also allows for some more unconventional needle placement. So remember in this, sorry, it's still low dose because this is a CT fluoro image, but here's the midline, and the midline, you can see there is epidural flow of contrast there, but I've actually come much more to the side and close to the facet joint. And why did I choose to do that? Well, this person, you can see actually even on the CT image is a big lytic lesion. Here's a huge destructive metastases that's causing the patient a ton of pain. So the goal here was to get as close to where that nerve root was being compressed by the tumor. And so again, CT allows you to do some more unconventional nerve placement. The problem is because even with CT fluoro, you don't get that live feedback the way you do with fluoroscopy, so you can look for intravascular flow. That I find is the major disadvantage of doing under CT, so I don't prefer to do it under CT. So that's not, in a lot of places they do it under CT, so you kind of have to pick your battles here. But to me, the risks of causing a cord infarction or something like that, or nerve infarction or some sort of problem it's better off to do it under fluoroscopy, in my opinion. All right, and so I just said that. All right, so moving on to the nerve root. Sorry, that was really fast, and I'm happy to address. If you have any questions, please feel free to email me or contact me. I'm happy to go over these things in more detail with you. All right, so the alternative approach is to do a nerve root block or a transforaminal epidural. So these patients generally either have had an interlaminar epidural, which again is bilateral, so it's more general, tends to cover more levels. These patients generally have very specific pain to one level, and it's radiating down the leg, so it's definitely sciatic and radiating in nature. And often they have sort of already had an interlaminar epidural, which is the more quote-unquote general injection, and it didn't work, so now we're doing a more targeted injection. So for this, there's sort of 3 levels of technique. There's L5, L4-5 and above, and then remember L5-S1 is the special unique level where there's always special challenges, and then S1. So there's 3 different areas. Above L4-5 and above, you can do either a straight or a curved approach. At L5-S1, you can do straight or curved, but it's going to be more curved. Yeah, at this level of 4-5 and above, we pretty much always do straight. 5-1, we try to do straight because the anatomy is easier. You'll see why when we do it. But curved is often needed because of the different roadblocks that are in the way. And then at S1, it's always a curved needle approach. All right, so, sorry, just doing a time check. So at the upper levels, this is when we do a straight needle approach, again, always start with a scout, check for your anatomy. Here, this time we're doing the right side. You can see this is oblique to the opposite side. So we're doing the right side of the patient, and you're obliquing it essentially to get a Scotty dog view. And you want to target immediately below the pedicle. Remember that the neuroforamen, the roof of the neuroforamen is the pedicle. So you want to go right below the pedicle with the Scotty dog view. Here's the other pedicle. And there's the pars interarticularis and the transverse process. So the transverse process can sometimes be an issue, can get in the way. So, and I'm sorry, this person is so osteopenic, you can't see it, but you want to look for the transverse process to line up pretty well with the inferior aspect of the pedicle as well, the inferior margin of the transverse process, so that it doesn't get in your way. All right, and here's the facet joint. All right, so here as we're going forward, here again, your pedicle, your transverse process, you bullseyed at 6 o'clock on the pedicle, things are looking good. And on the lateral view, you're getting closer to the target. And here's your neuroforamen. Remember, you want to go to the anterior upper quadrant of the neuroforamen. That's your goal. So we're still a little posterior, but we're just coming in. We're coming in. And here on the final, when you inject, it's on the AP. This is a little bit low, probably a little bit higher would be better. But what's good about it is that it's exactly 6 o'clock on the pedicle, so that's perfect. And you want to inject, again, at least 1 ml of contrast under pressure to look for intravascular flow, which is more common than the interlaminar epidural that we just showed you. And here you can actually see that there's also not only epineural flow, there's a epidural flow as well. And in the goal, when you do a transforaminal epidural, you have to get the the epidural flow. 5 to 6 o'clock on the pedal, epidural, and central epidural flow. And our injectate is generally a mixture of the steroid and anesthetic. And there's some variation here, again, how much anesthetic based on the patient's functionality and whether they're driving, that kind of thing. And also these ratios can change a little bit depending on the person. But, something for betamethasone, somewhere between 6 and 9 milligrams is, I think, generally in literature what people use. All right. So now if we're going to do, in the upper levels, we're going to do a curved needle approach. We actually do everything on the AP and the lateral. There's no oblique view, no Scotty dog view. So you start on the AP and you, in your mind, visualize or separate the transverse process into half. Break it down half and go halfway along the transverse process and mark the midpoint. And now you can see that there's a little curve on that needle, but you're trying to keep it lateral as far as possible. And now we're approaching, sorry, because of time, I'm not going to do the poles, but we're approaching here, this column here, which is the facet joint column. And the reason that's important to remember is that that's your widest point. If we go back to the AP, if we go back to the AP, that's here. This is your widest point. Okay, so once you get past that point, and remember going back to the anatomy, that's the floor. That's sort of your lower portion, your lower challenge. And so once you get past that point, you can swing in as hard as possible to get into the neuroforamen. All right, here's your facet joint. It's the lateral most clearance point. And then just past the midline of what you imagine to be the facet joint, then bring the needle tip as medial as quickly as possible. Now, this is the reason why we don't use this that often for the upper levels if a straight needle approach is possible, because in this particular situation, you're trying to go pretty much straight and then turn and at the last minute. And so you can imagine for a vector of a needle that's pretty much straight with a tiny curve, that's much more difficult to do. So it's much more difficult to get central flow with this technique, but sometimes for whatever reason you have to use it because there are roadblocks. So all right, so here I've passed the midpoint and I'm starting to curve in, and the end point is still the upper anterior quadrant of the neuroforamen. And now, why the upper anterior quadrant? We knew it's the location of the nerve root, but in the inferior half, you could potentially enter a disc herniation. So when you review the MRI ahead of the procedure, definitely check that, because like in this case, if there is a disc herniation, you can see that it's there blocking the inferior half of the neuroforamen. There's a disc extrusion. It can result in a discogram, and you don't want to do that. So compare the contrast pattern here with the level below. So you can see that the oblique contrast here along the nerve root going epidural, that's what you want. And the discogram is that straight contrast between the two end plates and along the intervertebral disc. So the problem here is that, I don't know, should we give antibiotics? The risk of discitis is pretty low per disc for discogram injections. And we very rarely do them here anymore. But when we did do them, we usually did this elaborate sterile technique where we had a surgical gown and hat and mask, and we added antibiotics to the injectate. And in this particular case, nothing was done, and the patient did fine. But you have to be a little bit worried about injecting steroids straight into the disc. So anyway, you don't want this to happen. So aim higher if possible, and definitely check your MR ahead of time to make sure you don't have a disc herniation there. And then the other thing is that the ventral ramus is the larger one that contributes to the sciatic nerve. Remember, right? There's a little posterior ramus and there's a large anterior ramus, and that comes down, joins all the other nerve roots from L1 all the way to S1, and then eventually you form the sciatic nerve and the sacral plexus and the sciatic nerve. So the ventral ramus is the one that's going to contribute to your pain and your sciatica. So since it comes anteriorly, if you target that area and you end up a little bit further anterior, then it will be okay. And we'll talk about why that might occur. But anyway, so just remember that you have a little bit of safety margin or extra space to go anterior in this situation. Here's your margin, about 2 millimeters anterior to the vertebral body posterior aspect. Okay, why is that? Well, because you can also have intravascular injection. Remember, it's even more common for this, for for the transfemoral approach than for the interlaminar approach. You can see these tubular vessels. Actually, you can see one even extending into the, the spinal canal. Even this person's had a laminectomy, but you can see the vessels going all the way in there. One other thing to remember is to look in the hub of the needle for a blush of blood too. So when you pull out the stylet, don't put the tubing on really super fast. Take a second just to see if you see any blood come out, because that a little blush can also tell you right away that you don't have, that you're already in a vessel. So in this situation, it's actually easier to advance through and rather withdraw from the vessel. I'm not actually sure why that is. I don't know if it's because the smooth muscle grips the needle or something like that, but that's the doctrine that I've been taught. And so remember, you have that 2 millimeter margin anteriorly. So if you see a vessel and you need to advance a few millimeters to try and get out of the vessel, you can still get a nice neurogram because you're still targeting the area of the main branch of the nerve, the anterior ramus, the ventral ramus. Okay, so, and then here, once again, we're in the facet joint. I'm going to move because we're running out of time, so sorry about that. And all right, and so, oh yeah, so when you have antrolisthesis, this can be really challenging too. And an alternative endpoint is patient pain. So whenever you're doing this, you want to pay real close attention to the patient's pain, because that can also, you may end up further posterior in your injection, unfortunately, because the patient already, based on their anatomy or whatever, already has pain. And so, these are sort of challenges that you encounter as you do them. Same thing, ending up on 5 to 6 o'clock of the pedicle and injecting, and you see flow along the nerve root, and you see central epidural flow. All right, so I asked this question before, which direction should I angle the II? And the answer is, so if the patient is prone and they're like this, you want the needle to come from, if you angle the II or the detector here towards the head of the patient, you can actually get around the facet. So imagine you tilt, if you tilt this needle upwards with the hub of the needle more towards the patient's head, then you're able to get around the facet joint. All right, so the L5 also has additional challenges here. You have a transitional level, and your approach is like that tiny little hole. Again, if you angle the detector towards the head, look at how much bigger that hole gets. And also note how you profile the disc. Using this profiled disc appearance as like an indicator can be really helpful. So if you're having trouble remembering which way you go, then try to make this disc nice and open, and seeing this disc nice and profiled. That's also where you're going to give yourself more space in the neuroforamen to get in. All right, so, and right, the sacrum is in the way, transitionality. Okay, so I'm going to, all right, so I'm going to move ahead. Sorry, I'm going to go a few minutes over, but I just want to get through the S1. That will be really fast. So which is the landmark that's helpful? And a lot of people will pick 1 because this is the neural arch that we look at to look for sacral fractures, but that's the anterior neuroforamen, okay? The posterior neuroforamen is actually underneath number 2. So number 2 is the S1 pedicle, and the neuroforamen, I don't know if you can hallucinate it, is immediately caudal to that. Now, when you have, next time you look at sacral or pelvic radiographs, look for that. Look for that lucent oval that's immediately caudal to the pedicle, and that's where you're going to target for your neuroforamen. And again, most of our patients are older, are extremely osteopenic, and you can't see it. And so what you just have to do is you have to trust that it's there and use the force, and you can get in, I swear. So here I'm looking, I can see all the pedicles, I can see the S1 pedicle, and that's where my neuroforamen is going to be. You approach by targeting the lower outer edge of the neuroforamen. That's this little dot right here, and there's a curved needle. It's a curved needle, that's why the trajectory looks funny, but the person is trying to fight the curve here. That's probably where the neuroforamen is. And then you go to the lateral once you get through, and the needle tip is just anterior to the posterior margin of the vertebral body. Because remember, again, we're targeting the anterior ramus, the ventral ramus, not the posterior ramus. So you want to get further anterior, and you start injecting on the AP, you get central epidural flow. And in this particular case, we actually got flow along the L5 nerve root as well. And always document all the areas in your reports. You want to document all the areas of contrast and medication flow, because this can have indications for the treatment, right? So like if say on one injection you did an S1 and the next one, you did two S1 injections and one of them you got to L5 and the other didn't, and the patient had better effect on the one that got to L5, well, maybe what they need is an L5 injection. So anyway, so always document all the areas where you see contrast flowing. And this is going to be my final quiz where I quiz people and stuff, but I'm run out of time. So anyway, if you remember nothing else from this presentation, I'm sorry I got really fast there at the end. Know your anatomy, and that if you position the patient properly, just for any procedure, it will make or break your procedure. So always remember those things. And thank you for having me. And I'm sorry I went a little bit over.
Thank you so much. That was excellent. Do you have time for a couple questions that came in?
Yeah, sure. I have time. I'm sorry. I didn't want to take up everybody else's time. So.
No, it was perfect. And it's good that we'll be able to record and sort of rewind and see it again. So thank you so much. The anatomy overview was excellent, technique and everything. So thank you.
Yeah, sure.
The first question that came in was, what is your opinion on subpedicular versus infraneural approaches? Do you have a preference? Do you not use one or the other?
Well, the infraneural approach can be useful, like if you end up in the posterior. In general, we do subpedicular because that works for most people and most of the time when you're targeting that level. Sometimes, say you really want to get, you're doing L5 nerve block at L5 S1, and you really want to try to get S1 flow. Sometimes going lower down and in that lower posterior quadrant, you can get flow of L5 and S1. So it's what your goal is, but I don't use that technique as often.
Got it.
And also in that area, often the facet becomes an issue. So, you know, if you've got a pristine 18-year-old, then sure, you have the option. But a lot of times in your 80-year-old who's got really degenerated, bulky facets, that posterior inferior recess is just not an option. So anyway, sorry about that.
No, perfect. Second question was for thoracic transforaminal epidural steroid injections. Do you ever use the rib as a highway?
I use the rib as a highway. I guess I could, but I don't really, because we do those under CT. So in general, I've been able to come straight into it without having to use the rib, but that's an interesting thought. And if you have a case, please show me. I'd love to see it.
Okay, I'll talk with the person who's asking. If you're doing multiple levels, do you typically inject them one at a time, or do you place the needles all at once and inject one at a time, or do you sort of do them one and then inject, take it out, next level, or do you have a preference?
So for that, it depends on which level. So remember that L5, S1, and S1 have unique positioning. So those you need to be treated separately. But if I'm doing a L2-3 and a L3-4, then yeah, I will position them at the same time because it's general you can get the same position to work for both. So it really depends on, you know, the level.
Okay.
The other thing is, sorry, I have one more thing to add to that. So sometimes actually with the L5 S1, for example, there's always a chance, even if you do a subpedicular approach, that you can get S1 flow. So if I'm asked to do an L5 and an S1 on the same side, for example, I will do L5 first because if I inject and I get flow along S1, which is not too uncommon, then I don't need to do the S1 injection. I just inject the entire medication dose there, and it saves the patient, you know, radiation and procedure time and stuff like that. So yeah, anyway, it depends on the situation.
Got it. If you end up experiencing the acute stenosis situation, do you try to aspirate the contrast?
No, because if you imagine, it's kind of like you've injected into a cotton ball, and it's not like you've injected into a joint or something like a open space, and you can aspirate the stuff back. You've injected into a cotton ball, so it's very hard to get it back. The only thing you can really do is wait. So you slow down the injection. So again, I guess the disadvantage then is that you don't see the vessels. But in this case, you got to pick your poison, right? So I just inject really, really slow, and I tell the patient, okay, when your pain reaches a 5, tell me, and I stop. And then you stop and you wait. And then, because it's a cotton ball, but it's a very large cotton ball. So the injectate is going to kind of diffuse away from the site of injection. So, you know, after a few minutes, unless they have really critical stenosis and it's super tight, the pain will improve, and then you just try to get in as much as possible. And in that case, I will often give up. You know, the goal is to get the steroid in. So then if you get the steroid in that situation, you're pretty much done. You don't move on to doing the flush, which is the diagnostic portion. You just have to give that up. So.
Got it. Last question. Do you ever run into circumstances where people ask you to do ganglion impar injections, and what would be the criteria to do it, and what would be your technique for that?
Can you say that again? Ganglion impar?
Ganglion impar, or one of the sacral ganglia, I guess, as they were asking about.
Oh, you mean like the tarlopsis? Is that the question?
Sorry?
Like a tarlopsis? Like a ganglion in like a sacral, like a nerve root ganglion? Is that what they're asking? I'm just trying to make sure I understand.
I think they were talking more of like a nerve ganglion, but
oh, yeah, nerve ganglion. Yeah, like a kind of like a tarlopsis. Yeah. Very occasionally, I looked into that. You know, in some places they're even injecting fibrin glue into those. Well, first of all, they are it's known to be very, very rarely symptomatic, because we see these large tarlopsis and they don't really compress the nerve root. And so they're very, very unlikely to cause symptoms. If, you know, in the very rare circumstance where people are, like the referring physician is convinced for some reason, or wants to try, I've tried everything, and, you know, wants to see if that's causing pain. I've aspirated, but I have not injected anything. Because if you inject, then you basically you make it big again after you've aspirated, because it's mostly for diagnostic purposes. And like I said, I did look at some papers where they were injecting fibrin glue, but I just feel like the risks of that are just too great. I mean, what if the fibrin glue leaks out and you're right next to all these sacral nerve roots? And, you know, what if you cause some sort of arachniditis or something? I mean, I just think the risks are too great. So anyway, I have done it, and it's only for diagnostic purposes. So I only aspirate, and that's it.
Got it. Okay, well, that exhausts all of our questions. So again, thank you so much for your time. Excellent talk. We all really appreciate you taking the time out of your day to do that, and look forward to seeing more things coming from your group.
Sure. Thank you so much. Thank you again to everyone, all of you guys at Emory, for having me. I really had a great time. Thank you.
Thank you so much. Everyone have a good day and stay safe.
You too.
All right. Bye-bye.
All right.